Yes, 10 years ago, I didn't think I would be here moderating such a session, but I'm honored to be part of this. My name is Shabe Doreen Kasule, a critical care nurse, and currently I'm in charge of the neonatal unit in Mbarara Regional Referral Hospital. I am joined with a number of specialists. We can call them experts. Today, this is our 26th eco session, and we are going to talk about an approach to a child and adult with sepsis. So I'm going to welcome the experts to introduce themselves, and let us start with you, Dr. Agri.
My name is Agri Lubikire Joseph. I'm an anesthesiologist, intensivist, and evacuation physician, and I'm a seasonal DJ. And I practice from Ginger Regional Referral Hospital and lecturer for anesthesia department at International University and adjunct lecturer for Sitama University as well, anesthesia department.
Yes, thank you very much, Dr. Agri. And next we'll have Dr. Rachel.
My name is Chirabo Rachel. I am a general surgery fellow at Mulago National Referral Hospital.
Yeah, we are also joined by experts virtually. So I will request Dr. Raya to introduce herself. Dr. Raya?
Okay, hello everyone. My name is Dr. Raya. I'm an emergency physician and also head of pediatric emergency in my hospital. I'm also honorary lecturer of Muhimbili University.
Yeah, for those of you who may not know, Muhimbili is actually in Tanzania from our dear President, Samia Suluhu. So we are going to request Dr. Sonia to introduce herself.
Hello, everybody. Thank you for having me. So my name is Sonia Jarrett. I am one of the Pediatric Emergency Medicine Fellows. I'm located in Boston, and I work at Boston Children's Hospital. Very happy to be here today. Thank you for having me.
Thank you, Dr. Sonia. I'm sure everyone knows where Boston Hospital is, but just for a reminder purpose, Boston is in the US, in the United States of America. Thank you for joining us. And next we'll have Sylvia. Yes, Sylvia?
Good afternoon, members. I think I'm unable to show my video. I was not made co-host, but I'm Sylvia Namaganda, a critical care and emergency nurse at Nakasero Hospital. Nice to meet you, members.
Thank you, Sylvia. And I want to thank everyone for joining us. We are currently having our pretest ongoing, so I will encourage you all to go on and fill in the pretest. We want to see where we stand. We assess ourselves so that at the end of this session, we're able to know if some learning has taken place. Yeah. So as we continue with the pretest, I am going to request Sylvia Namaganda, like she introduced herself, a critical care nurse, to carry on with the case presentation. And yes, Sylvia, please carry on.
Hey, Ibra, can Ibra share for me the slide because I'm unable to share. I was not co-host,
Yes,
so
I'm
I'm not
going to share.
okay. So our case today is about an adult. It's an adult case for a patient who came in with.
Okay, so Sylvia,
Yes.
I'm going to request you to just hold on a little bit. Let us allow more people to fill in the pretest. Just hold on a little bit so that we have more people filling in the pretest, and we'll show the polls when we finish this, and then you can continue. As people are filling in, please, today, this is going to be a very good session, and I request everyone, wherever you are, please remind even those who haven't logged on to join us. There's a lot to learn. This big elephant in the room, sepsis. Everyone talks about sepsis, but what is sepsis? Yes? So remind everyone to join us. We are going to talk about the pediatric bit. We want to know, how about in the adults? Yes? Is it any different? What are the guidelines? I don't want to preempt what my experts are going to say, but I encourage you all to continue filling in the pretest. And maybe I will request 3 people to actually type in the chat box what your expectations are of this session, and that will also help guide us so that we can actually flow together. Yes, thank you very much. Some of the things that we are to talk about, we are planning to talk about common causes of sepsis. How do we assess a patient with sepsis? What investigations? Yes, we are back. We apologize for that. There's an IT glitch, but it's been sorted. Okay. So we request you all to fill in the pretest. Thank you all for joining us. Yeah, continue, and please remind others to join in. This session is going to be very fruitful. How many more do we want? Yes. Okay. Yes, thank you very much. And we are done with the poll. So we are going to carry on with the case presentation. As you can see, our critical care and emergency nurse, Sylvia, is ready to take us through. Sylvia, are you there? Sylvia, are you there? We continue?
I'm there, but I'm still unable to turn on my video. I think,
Okay,
can we just move on?
it's okay, they're going to sort it, but let's continue with the presentation.
Okay. As once again, I'm Sylvia Namaganda, critical care nurse from Nakasero Hospital. So I'm starting on our case today. Our case today is our case first. Later on, we shall get the pediatric case. So we have a client, a patient. Let's start with the history. We have Diggy, as a 46-year-old male, was brought to hospital emergency room with a referral from a hospital. The patient gone to the hospital with.
Can we mute these people?
But ruling out acute appendicitis, was and done explorative hemicolectomy and was admitted for 5.
You've also muted Sylvia.
Now he muted me.
Sylvia? Hello, Sylvia. Sylvia, are you
Yes,
able to
hello,
hear us?
I'm back.
Yeah, kindly continue.
So the patient became weaker after 5 days and was referred to Kampala for further management. Next slide. On assessment, the airway was patent. The patient was talking, no snoring, no grunting. Breathing, he was breathing spontaneously with normal breathing patterns, equal air entry bilaterally. SpO2 was 95 to 99 on 5 liters of oxygen via nasal prong. Circulation, patient was hemodynamic. Patient had warm tachycardia with a respiratory pulse rate of per minute, 49/79. Patient had a 18-gauge cannula on the right arm, which was patent. Disability, the patient was sick-looking and drowsy, semi-conscious, with GCS of 14/15. PAL, temperature was 37.8 degrees Celsius. Exposure, the patient examined from head to toe. He was critically ill, lethargic, he had sunken eyes, skin pinch returns after 2 seconds, mild conjunctival pallor, no jaundice, no cyanosis, no edema, no lymphadenopathy. He had an NG tube in situ, weight was 78 per abdomen. He had a mildly distended abdomen, had an abdominal line incision scar with dirty dressing. He had a stoma with a colostomy bag, which was draining, abdominal tendon due to the surgical wound, no palpable organomegaries. The colorectal exam was not done. Next slide. So the impression was intra-abdominal sepsis. Problem list, we had low-grade fever, temperature of 37.8, dehydration, mild anemia, HP of 9, abdominal pain, which he rated as 6/10, moderate abdominal distension, and mild tachycardia with a pulse rate of 112 beats per minute. Investigations were done. CBC, the white blood cell count 16.68, neutrophils 15.28, lymphocytes 5.3, HB 9.6, MCV 79.7, platelets 238. CRP was 210.8, extended electrolytes, sodium 138, potassium 3.8, calcium 2.18, albumin 27.6, serum amylase 143, lipase 53.5. Blood culture and sensitivity was done, first swab culture and histology, then abdominal scan. So that image you see right there is the CBC. I don't know if you can see it clearly.
Yes, I'm sure they can.
In the investigations I have just read before. So these images down here, the images were showing how septic surgical wounds, but these are not the wounds of our patient. These are just for our study purpose. So in management, blood culture was taken off before starting new antibiotics. IV fluids, fingers lactate, saline, D5, 3 liters were given in 24 hours. IV pizza, 0.5 gram 8 hourly. IV metronidazole, 5.8 was kept per course. Total parental nutrition was given at 60 mils per hour. IV paracetamol, gram 8 was supplemental oxygen, 5 liters via nasal prongs. Next slide. So in management, we did again, vital signs were monitored closely. Surgeons review, wound dressing was done and a VAC applied. Blood transfusion with 2 units of packed cells. Physiotherapy and was done on the ward. In summary, we have a 46-year-old male for intra-abdominal sepsis, post-explorative laparotomy, antibiotics and taken back to theater for second wound closure. He stayed in hospital for about 30 days and was discharged home later on in a very much better condition. Thank you very much, ladies and gentlemen. That is our adult case today.
I would like to welcome you all back. Thank you very much, Sylvia, for that case presentation. And this gentleman, DG, the 46-year-old male, the diagnosis was intra-abdominal sepsis, yes? But he was evacuated to Kampala after 5 days, I hope you noted. And then he was discharged after 30 days. That was the length of stay in hospital. So I am going to call upon our surgical expert, Dr. Rachel Kirabo, to chip in and say something. Was this case really managed well? Would you like to add something? Yeah, as you continue.
Thank you very much for the presentation. This case, well, in my opinion, this case was managed well because the patient went home and he recovered completely from the sepsis. And but like he was managed in an advanced, I think, in a good setting, so they were able to access the vacuum-assisted.
A state of the art hospital.
He was managed in a good hospital, were able to access vacuum-assisted closure. They were able to, do blood cultures and give strong antibiotics, which helped him a lot. But in a place where one of my comments that in some hospitals they are not able to, because one of the major components of managing sepsis, surgical sepsis, is source control. So these people in this setting are able to access vacuum-assisted closure, which uses pressure to pull fluid out of the wound, because this patient had intra-abdominal sepsis. So there was pus in the abdomen, which was the wound had, in the pictures we have, the wound had given way, so pus was coming out from the wound. And that pus, there was a lot of pus probably still inside, which was causing him to be very sick. So I think the vacuum-assisted closure played an important role in managing his infection, because it was able to pull fluid out of the wound as the wound is coming together. But in another setting where you don't have vacuum-assisted closure, where the dressing is not sufficient, sometimes you can opt to go for a relap, a second laparotomy, to wash out the pus, because sometimes it collects, inside the abdomen, in the recesses, and in another setting, probably maybe they would have, if they had stayed in the village and they have a surgeon, maybe they would have opted to do a second laparotomy to wash out. Sometimes they even do 4 laparotomies or 3, as long as all the pus is washed out and the patient is improving, and also to help the body to fight the infection better. And also I want to comment that the first surgeons who operated on the patient, I think they also did a good job, because usually in patients who have bad sepsis and intra-abdominal soiling, putting a stoma is one of the good options, better options, rather than doing primary anastomosis. So these people put a stoma on the patient instead of doing a primary, which shows that they did probably damage control surgery, and they didn't want to take so much time in the surgery, and they put a stoma, and I think they helped the patient a lot. And then this patient was on strong antibiotics. They were dressing the wound, and according to the presentation, it's not clear when the secondary closure was done, but most of these patients, usually the second closure is done after a long time, I think like 2 weeks, 3 weeks, and sometimes we even allow for secondary wound healing, where we don't have to close the wound, but just soothe by it. So,
yeah.
My comment.
Thank you very much, Dr. Rachel. You have heard from the experts. She emphasized source control when you're managing sepsis. Source control, yes? And in this case, they actually used vacuum-assisted closure. Yes, we are going to go on to the next bit, whereby I'm going to request our critical care specialist, Dr. Agre, who is also a seasonal DJ, in case you didn't know that. He's going to take us through the introduction to sepsis. Dr. Agre, you're welcome.
Good afternoon, everyone. Thank you, Doreen, for the good introduction, and thank you, my colleague, and everyone else who is attending, but also who is contributing greatly to this learning session. Mine is a simple task to lay just the foundation of managing sepsis. First and foremost, sepsis is a pandemic. About 11 million people die every year, and it could be more because in Africa or in Uganda we have issues of data collection and reporting. So you find that we have a lot of undocumented deaths. So I'm sure the number is bigger than that, but sepsis is a big medical emergency. It's a world problem, and it's more in Sub-Saharan Africa, where we keep on losing many people every year. What is sepsis? Basically, sepsis has changed quite a lot from 1991. Many definitions have kept on evolving. To date, since 2018, we have a new definition that looks at about organ dysfunction as a result of a dysregulated host response to any kind of infection, which can be bacteria, virus, protozoa, fungal, to mention but a few. So we no longer have definitions of severe sepsis or septicemia with the new definition. So it's either sepsis or septic shock. Mortality when someone has been diagnosed by sepsis is quite very high. About 25% patients with just a single organ die, and about 2 organs we have over 40% mortality rate. If you have 3 organs, your percentage of death is about 75%. What this means is you're going to use more resources to survive. You still have a high chance of dying, but also you're going to have a longer stay in hospital. And the case in point now that we just discussed kind of highlights the risk when you have a single organ and then complications. It takes quite a while for you to survive in background. So the more the organs, the worse the outcome. So your mortality, depending on the number of organs, will worsen. Further still? Yeah. Next slide. Sepsis. Just look at that under avalanche. When someone is having sepsis, you have a pending avalanche ready to roll on the population down. So when you talk of the sepsis cytokine storm, it's the best time to actually address the patient's problems before they decompensate. And most people miss that critical time to either execute treatment, either resuscitate the patient or optimize the patient, like we normally say. And by the time they start instituting the right treatment, a cytokine storm has already descended on the patient, and the patient is struggling with different organ dysfunction. Next slide, please. Many things can present with sepsis, or can pretend to be sepsis. Many of us remember when we first fell in love, we had high heart rates, we had increased breathing rates. Some of us were light skinned, were already flashing or becoming red. Some of us collapsed when they told you, I love you. Some of us became manic and depressive. All these signs actually cut across sepsis. So do not go diagnosing people in love to be septic or septic shock. However, the things that really actually cause sepsis, we have bacteria, which is most common with us, fungi, parasites, viruses. And if you look at that intersection, all of those can just interact. So if there is no time when you can say, oh, this patient has only bacteria. There are times when you have bacteria, parasites, fungi, viruses. The more the microbial organisms you have in the body, the worse your outcome, and the more you need treatment and support. The things that can predispose us to sepsis can be many. It can be infection by per se, but can be trauma, can be burns, can be even certain parts of the body. Hepatitis. Next slide, please. When we have sepsis, we have the innate immune system, the pre-septic immune state, where you have maybe good genetics, maybe your age will protect you, a good environment where you've been very fit, and may not have comorbidities. But if you have anything, for example, extreme of age, like pediatric cases, or extreme of age above 60, maybe you've been in hospital setting where you picked up hospital-acquired infection, maybe you have diabetes or hypertension, or you have heart disease, maybe you pick up a very strong back. That kind of will lead to injury in your body where you have an inflammatory response, and your body will try and fight back. So you have the two systems, what we call a pump system, which is pathogen-associated molecular pathways, and then the fight again that will lead organs being fought and damaged. And you have what we call the damage-associated molecular pathways, and this will lead tissue injuries with lots of pro-inflammatory markers or pro-thrombotic markers or vasodilatory markers. So you may find a situation of sepsis that the patient either getting septic shock because you have a lot of vasodilatation because of the different molecular inflammatory release, or they may be getting prothrombotic, or both of them. And this can either may be well resolved by your body and you stay in sepsis, or you can actually get worse and need fluids together with vasopressors. That's when you have septic shock. Next slide, please. That's just highlighting what I've just discussed. So how do we assess sepsis? Two ways. We can look at what we call the sepsis-related organ failure assessment, which looks from head to toe. We look at the level of consciousness of the patient. We look and then we score it. We also look at your blood pressure. Are you in shock or not? And do you need vasopressors? We look at your respiration. Are you failing? Are you in acute respiratory distress syndrome? We look at our liver function. If you have a drainage liver function with a lot of bilirubin, we look at the hematology function, where we look at your level of platelets and then your level of kidney function. All those are scored, and the higher your score, the worse you're sick and the worse your prognosis, but also the worse the cost of saving you. That has a challenge, especially when you have the source setting, because you need biochemical or hematological indices that may be costly in a role set setting. So then we have QSOFA, which is quick SOFA, where we look at parameters like central nervous system, where we look at level of consciousness, we look at our respiratory rate, and we look at our cardiovascular system in terms of blood pressure. So this QSOFA actually helps in low research setting, where you can actually pick up those patients who are either compensated or decompensated, or who attend to be decompensated, so that they can be optimized and given high dependence beds so that they can avoid getting any worse. QSOFA is also good for prognostication. Yeah, next slide, please. So that's what I've been discussing, the different scores of the sequential organ failure assessment. And that describes that if you have a score of 7 to 9, you have a mortality of 15% which is quite a big mortality. And with these researches which have been done in high resource settings, so you can imagine in a low research setting like maybe Ginger Hospital where I work, where when you talk about use of good antibiotics like this are they used in this patient, just that it may not be affordable, it may not be very accessible, which may be a challenge. So the higher your score, the worse your mortality. Like someone has 15, it means they can be salvaged but have a high chance of dying. And that means also you need a lot of money, and you're likely to stay longer in hospital. Next slide. That's the quick SOFA, and that's how we look at our patients. So in the event that also you can't do some of these scores, you can actually at the emergency department look at the mnemonic called T time. Anyone who has hyperthermia or hypothermia, anyone who has signs and symptoms of any infection, anyone whose level of consciousness is deteriorating, and anyone who is extremely very sick, all these can actually give you an indication on how to address these patients without waiting to do all the labs. You need to attend these patients at your earliest opportunity. But in case you are able to afford the investigations, the next slide please. We should try and do, first and foremost, before you start running investigation, you need to do your ABCDE. Make sure that actually you have a live patient on who you're going to take on these investigations, because it's useless to just take all these investigations when the patient is dying on you. So first and foremost, airway should be intact, breathing should be intact or supported, saturation should be okay or supported. We should do our blood sugars and also expose the patient in case maybe they come as a trauma patient, or examine and find out the source where the pain is, like for example, if you're expecting acute pancreatitis, appendicitis, you should be able to kind of find where my burning point is and be able to kind of get a vague feeling of what's happening. But by and large, we take off our complete blood count. At this time, we should also do the 1 hour band where we take off, we administer a broad spectrum antibiotic. If the patient has been already given an antibiotic, then you do your blood cultures from different sites of the body, not on the same site. You take about 10 mils from 2 different sites, which will be 20 mils for for aerobic and anaerobic infection. But at the same time also, you need to do an MIC, minimum inhibitory concentration. So for example, I've been started on ceftriaxone, maybe 1 gram start. Is that adequate enough to address 50% of my colony to show that it's working. So that's why you do the MIC. So sometimes people are hesitant to do a calcium sensitivity because they've read that means an antibiotic. But when you do that, ask for an MIC to know if your separation is working or you need to increase the dose, maybe to 2 grams instead. Then we also do our lactate levels if we are able to do the lactate, because it's a good surrogate to know how the compasses in terms of tissue perfusion is, but also when you start perfusing with fluids or resuscitating with fluids, then you're able to understand if the cells are improved in terms of cellular metabolism or perfusion. The other thing also, we start 30 mils per kg of body of fluid resuscitation from the trial that have been done, the SAFE trial that was about 7,000 patients, a world trial, multi-center in Australia. They encourage crystalloids or colloids at this time in terms of resuscitation. So whatever you have, try and resuscitate the patients. If the patient is very anemic, please give blood, not start fluid filling up with the patient with crystalloids. Also, as a caveat, they recommend 30 mils per kg, but you have to individualize your care to the patient. If the patient has cardiac problems, you're not going to fill them with fluids. If the patient already has CKD, you're not going to fill them with fluids. If the patients are extreme of ages above 60, below 5 years, they have issues of glomerular filtration. So from the first trial, it was proved, which was a trial that Uganda was even involved, that moderate fluid resuscitation actually is very good and early starting of vasopressors. So we have to be very careful following guidelines. Every time you get a patient, try to individualize your care. Other thing we normally do is radiological investigations. Part of the biochemical profile we can do is what we call the biofire profile, which is the latest gig on market in terms of infection screening. Biofire profile, you screen close to about 30 organs, microbial organisms, but you can take fluid from CSF, blood, anything from the lungs, anything from the abdomen. And the bit about it, it will identify the actual microbial organism that's affecting either parasite, bacteria, viruses. So you're able to kind of also help in terms of treatment. Next slide. That's just a summary of our sepsis 1 hour bundle. Next slide. Okay, next slide as well. So we have also what we call adjuncts, or things that we might need to use to optimize patients. Let's go to the next slide. It has been proved that early use of steroids following the adrenal trial has lessened number of days. Like for example, such patients we had, if the patient was maybe in shock, they could have been given hydrocortisone. You load them 200 milligrams start and then do 50 milligrams every 6 hours, at least for 72 hours to improve on their cortisol levels so that they do not decompensate in terms of circulatory support. And this has been proved to decrease the later days, but also to help with early reversal and also minimize the number of blood transfusions. Next slide, please. Paul Merrick did a trial on use of vitamin C, thiamine, and steroids. And also this study was done by, again, was related by the Victor's trial, which is vitamin C and thiamine use and steroids. There have been equivocal findings, but by and large, the physiology behind the use of vitamin C is very, very strong, because vitamin C is needed as an antioxidant in the body, but also it actually helps to improve the inflammatory cytokine storm that we are fighting at that time, but also helps our body response to our own body cells in terms of fight. And then thiamine has been also shown as a cofactor in the manufacturing of ATPs, but also it's renoprotective for patients who are having sepsis from getting sepsis injuries. Also, steroids I've just talked about. So use of thiamine is very, very strongly recommended, steroids and vitamin C, but also you choose which patients you can try. Most good results have been shown to come out when you administer these things very early in the first 12 hours. One of the other things that you can do is administration of using adsorption therapy. Next slide, please. Where you remove the inflammatory markers like interleukins when you're dialyzing these patients, so that they did not have a big build-up of the cytokine storm. And this has also shown to improve outcome. Next slide, please. Alnastatin is more an immunomodulator. A big trial of over 3,000 patients was done in China to prove this, that early use within the first 6 to 12 hours actually is associated with better outcome, but also improvement in ARDS outcome over 28, and also a decrease in the 28-day mortality. Next slide, please. Most of our patients who are in ICU who are diagnosed with sepsis are highly catabolic. So nutrition is very, very important. And ASPEN, which is American Society for Parenteral Nutrition, encourages either to use either parenteral or enteral. The outcomes are the same. You can either combine high protein or low protein depending on your patient. So that means you individualize the care, and also low calorie or high calorie. So it means every patient has to be assessed for their caloric requirement and protein requirement. Next slide, please. There's always a challenge of use of antimicrobials when you are dealing with sepsis-related AKI. So some of these patients, we need to start timing early enough to protect them from going that direction, but also when they're already having dialysis, we need to be protective of them. The challenge comes in when you do antibiotics. So if you're doing antibiotics, your initial dose should be a big normal recommended dose, and then you tailor the other doses subsequently based on your creatinine clearance. Source control has been talked about, either open up the patient and lavage and clear up, or you can also do a colostomy, or you can do also a vac dressing. For patients who are not responding to conventional care because of septic shock, we are encouraged to use, besides if you're using noradrenaline, then you try adrenaline, and then you add arginine vasopressin and you're not responding, then you can add a new drug called angiotensin 2. Challenge is still very, very expensive, but it has been also shown to help a lot. Special groups that we need to watch out for are pregnant mothers because of their changes in their physiology of pregnancy. It lowers their immune system. So these are very, very prone. And when you're treating them, remember you're treating 2 patients. The mother and the baby are at risk. The elderly, next slide, please. These already have a decompensated physiology and they tend to have more comorbidities. So when you're dealing with this, sometimes you need team approach so that you can get the best in terms of recovery. Next slide. Patients on HIV also tend to have already decompensated many organs, either complications from the virus itself or from the medication. So when you're addressing this, involve your IDI specialists and also other specialists depending on the patient's issues. Next slide. Cancer patients also tend to have immunosuppression, either because of the cancer itself or because of the medication we give them. So also this, when you're treating them, involve the other team members so that you can address their challenges. I think that was done already. My take-home message when you're dealing with a sensitive patient of sepsis, try and be purposeful. Keep it simple or keep it super simple. We call it the KISS principle. I already give the example. If someone has bad breath, don't tell them to go chewing gum. Just tell them to go and brush. That's the best source control you have for them when they have bad breath. Thank you so much. I shall welcome questions.
Thank you very much, Dr. Agre. There's a lot, I am sure there's a lot people have learned today. There are things that are tickling their brains. And he talked about a number of issues. So before I bring in Dr. Sonia, maybe to say something, you actually, I like the bit where you are actually giving us all these articles published to really emphasize the evidence-based care that we always talk about, yes? The purpose of research. And maybe I have something that maybe Dr. Sonia could elaborate more on, or you could actually talk about. You talked about the QSOFA. So you say this would be the best in a low resource setting, but what exactly is QSOFA? Did I miss that bit? What are we looking at when you say QSOFA? And then you talked about MIC, This seems new for some of us. Maybe I didn't hear that bit. People out there could be more informed. However, for those who are like me, who want to learn, so I'd like us to understand the MIC bit. And then the steroid use, while we are talking about immunocompromised people. Yeah, so help us understand that bit as well. Yeah, Dr. Abre, then I'll request Dr. Sonia to chip in also. Thank you.
Okay, so quick SOFA, which is published by Seymour and these colleagues, looks at 3 parameters. Respiration rate, anything above 22. With this, I must say, if you're pregnant, we look at above 25. Because naturally pregnant mothers are alkalotic, they tend to breathe fast. Altered mentation, anyone whose glaucoma scale is falling down, we start also getting interested in them, and we start also scoring them. And also blood pressure, so anything less than 100 systolic. So we score from 1, 2, and 3. Anyone above 2, we know you're not doing very well, so we need to start addressing your issues, either in a hospital like a low-research district hospital or regional referral. You may have a rapid response team, inform that team, they try and review the patient and see if the patient needs review via CNS why they are deteriorating. Maybe some blood samples may be taken. In our environment, malaria, bacteria are very, very prone. If it's the elderly, do a urine screen. If you think the patient is surgical, take some samples to just so that you know what's going on. But the worse the score, the more the patient needs to move either from HDU to the ICU. So you find that these parameters kind of help you to pick up those patients who are at risk, who may need optimization and they improve, or who are already optimized but not improving, that they may need to push the next level of care. The bit about it, it's affordable. All you need is just have a chart where you have this and you can pick up these patients as part of your daily routine when you're doing a ward round or when you're at the emergency department. Who stays and gets discharged, who stays and goes to the ward, or who stays and goes to the HDU for admission. And that is kind of a simple screening tool in our low setting. MIC is basically minimum inhibitory concentration. So when you administer an antibiotic, sometimes there are different dose ranges. I'll use ceftriaxone. You have 25 milligrams per kg, 50 milligrams per kg, and 100 milligrams per kg. Sometimes you may be judicious and say, maybe I'll use 25 milligrams per kg. And you're not very sure if this is the right dose for this patient. So you take off your blood samples for culture and sensitivity. That's for aerobic and anaerobic, but also mention that you've given an antibiotic and request for the MIC. So the person in the lab will try and culture the blood samples. Again, it's all possible microorganisms, depending on the hospital-specific antibiogram, and find out how many of those will grow. So typically, MIC will refer to the minimum dose that is required to inhibit 50% of growth of microorganisms in any given culture. So if the dose given cannot suppress 50%, it means it's working, but we need a higher dose. So that means we will have to increase on the dosing, but doesn't mean the antibiotic is not sensitive. So the antibiotic may be sensitive, but low dosing. The last question was steroids. Yes. Critical illness causes our adrenal glands to shut down, and yet all of us need the adrenaline in our body to fight. So the steroids give us this drive. In terms of wound healing, in terms of hormonal function. So when your steroid level goes down, you need a boost. And this happens a lot in critical illness. That's why we need it. Yeah.
Thank you very much, Dr. Agri. And I want to welcome everyone. I'm seeing people from Gulu, we have people from Windi, we have people from Barara, and as far as Moroto. Of course, you also have people beyond Africa. You're welcome. So I am going to welcome Dr. Sonia to also say something about that. However, as you're giving us whatever you have to give us, Dr. Sonia, I'm requesting maybe you could add in which other people could be at risk for sepsis, apart from the few special people they talked about. Thank you. Dr. Sonia?
Great. Thank you again for having me. And thank you, Dr. Agre, for giving already an excellent overview of sepsis. So I would like to mostly just add in some of the updated or current guidelines for sepsis, which are also a bit of a summary of what Dr. Agre has discussed so far. Would someone be able to share the slides I had sent or make me a co-host? I currently cannot share screen. Okay.
Dr. Sonia?
Yes.
I wanted you to add in something. However, we are going to give you time to share the slides.
Okay.
Do you have anything to add on to what you said before your presentation?
No. I'm afraid the connection was challenging. The question was, are there other populations that are at risk for sepsis?
Yes.
Is that correct?
Yes,
Oh, great.
please.
Perfect. So I think so far, people who have been mentioned, truly actually anybody is at risk for sepsis. That's the very scary part about it. And from a very young age, neonates are very at risk for sepsis because they have not had a developed immune system yet. They are also, just underwent stress from birth and also have exposures to new bacteria and illnesses. So the neonatal population is very high risk and they can deteriorate very quickly. Children also are at risk. They usually, when they do have sepsis, have a high mortality rate as well. And then I think others, whether adults, especially immunocompromised patients, tend to be high risk as well. But I think that has just already been mentioned, so I don't want to take too much time on that.
Thank you very much, Dr. Sonia, for that addition.
Mm-hmm.
And I am going to request Dr. Raya. Dr. Raya is going to take us through the approach to a child with sepsis. Dr. Raya, the floor is yours.
Okay, hello everyone. So I'll just share my screen, 1 minute. Okay, so I'll talk about approach to pediatric patient with sepsis. So I have a case, 2-year-old patient present to ED with a history of high-grade fever and difficulty breathing. On examination, the temperature was 39.5 and SpO2 was 85. The respiratory rate was 45 beats per minute and the blood pressure was 90/60. So my question is, how will I know if this kid has sepsis? So first of all, I need to recognize if this child has sepsis. As we all know, sepsis is the dysregulation of the inflammatory process. So in our setting, we use SARS criteria, which has a component of temperature, tachycardia, high respiratory rate, and a leukocyte count. But if the patient has more than one criteria, then we regard this patient as having sepsis. But one of the criteria should be a leukocytes count of greater than 10% bound, or temperature of 38.5 or low as less than 36. So how is it different from an adult? Because there is a different source of infection until when the patient is getting sepsis. What are the sources of sepsis? So it can be skin or GIT infection, which cause a sepsis, or it can be maybe the patient has lung issue, or the patient has a urinary tract infection. Those are the major source of sepsis. So for pediatric, the common source is a respiratory tract infections. These are the commons, which is different from an adult. Also in pediatric, we use SARS criteria rather than QSOFA criteria. So which is easier for us to diagnose a patient with sepsis. So if I manage to diagnose this patient has sepsis, what should I do next? So if you're working in the emergency department, we usually start with primary survey. So you make sure the area is patent. Then you move to B. If the patient has, because most of the pediatric patients, they come in with their respiratory issues, then you have to categorize if this patient has a respiratory distress or this patient has a respiratory failure. How do I know if this patient has a respiratory distress and not a respiratory failure? So first of all, we have to look to the respiratory rate. If this patient has high respiratory rate or is very low respiratory rate. If the patient has very high respiratory rate, then that is a respiratory failure. And if the patient has very low respiratory rate, that is probably a respiratory, if the patient has very high respiratory rate, that is a respiratory distress. And if the patient has very low respiratory rate, that is the respiratory failure. But also you should also look at the respiratory effort. If the patient has increased respiratory effort, that is respiratory distress, and if the patient has very low respiratory distress, very low respiratory effort, or we call it shallow breathing, that the patient is having a respiratory failure, and that is the patient you need to intubate. Then, if the patient has a respiratory distress, then you can just choose which device should I use to put this patient on oxygen. Then you reassess if you have decided to keep this patient on oxygen device. If maybe it's a non-rebreather or nasal cannula, it depends on the saturation. Then you move to C. You assess this patient. Then you look to the extremities. If this patient has cold extremities or has warm extremities, how about heart rate? In pediatric, we usually don't look into blood pressure. We are more concerned about heart rate, because the heart rate will make you pick early if this patient has sepsis. Because when the patient is coming in with a low blood pressure, we say like we are late. We'll probably less likely will be able to save this kid. So we look into heart rate. If the patient has very high heart rate and also they have a cold extremities, then we categorize this patient as shock. Then, because you are doing A, B, C, D, E, you need to intervene before moving to the next step. So we start this patient on IV fluid. How do we give IV fluid? We start with bolus IV fluid. We give 20 ml per kg bolus. When we say bolus, it means we have to give the fluid within 5 to 20 minutes. Then you need to reassess, because kids is different from an adult. They are more prone to get a fluid overload compared to the adults. Also, you have to be aware, before giving 20 ml per kg for this kid, you need to rule out if this kid does not have anemia or is not having malnutrition. For my kids with malnutrition, you need to give 10 ml per kg. And for a child with a very severe anemia, we usually, you're supposed to order blood. And if the patient you see like he cannot sustain until the blood comes, then you can start on IV fluid like 5 ml per kg, but you have to start it very slowly. Also, you have to make sure like this issues is, also this kid does not have a cardiac issues. Because if she has a cardiac, or she also has cardiac problems, then you need to be very, very careful when you are giving fluid. You need to give a fluid very little and should go for very, very slowly while you are trying to rule out other causes of sepsis. Then you move to D. When you at D, you have to analyze the consciousness of the kids, which we use AVPU, which is also different from adult, where they use a glycoma score. So if the kid is alert, you can move to D. If you see this kid is maybe just responding to verbal, they maybe they're responding to VPU, probably this kid, they have hypoglycemia. They usually also present with hypoglycemia when they have sepsis. So you have to start this kid on dextrose. You can use 5 or 10% dextrose. If it is 10, you use 5 mils per kg. And if it is 5, then you should take 10 mils per kg. We have to be very careful not to use a 50% dextrose because it can cause necrosis, which is also different from an adult. Then when you go to exposure, you have to examine this patient if they have rashes. Also, you have to take the temperature and see like this patient is hypothermic or this patient is very febrile. When you are done with a primary survey, you can reassess your patient and see if they have responded to what you have given. Then you can go to ample history. See if this child has any history of allergy, if the child was kept on any medication, and see if this child has any other chronic illness, especially cardiac issues, malnutrition, together with anemia. Then you have to ask when was the last meal. After asking what was the last meal, then you go to exposure. I mean, you go to the event whereby you ask the thorough history of this kid illness. When was it started? Was this child kept on any antibiotic before? Also, don't forget to ask if this patient has been using any herbal medication before. That is also very important. When you are done with ample history, you go to secondary survey and do the thorough examination from head to toe. After diagnosis, child has a sepsis, then you have to individualize the treatment. See if this child needs more IV fluids or this child. You have also, before moving to the management, you are supposed to do the investigation. Because as I said before, these kids probably will come with respiratory issues as the main cause of their sepsis. Make sure you do the chest X-ray and take a blood culture before giving antibiotic. This will help this kid this will help you to know if which type of bacteria will this child has and which antibiotic should be given. Then if you have a luxury of doing ABG, that's good. You do the blood gases and see if this kid is having having acidosis. And if you also can do lactate, that is better because it will help you to know if these kids will need more fluid. If you have also luxury of doing ultrasound, is good. See if the IVC is okay or this child needs more fluid. Then go to the management. Management, sometimes antibiotic use is different from one place to another. So use what is recommended in your area. For us, we use ceftriaxone and metronidazole. I don't know about Uganda, which antibiotic do you use? And another issue I want to talk about is IV fluid. You have a room of giving 3 boluses, so you can give 20 ml per kg, 20 ml per kg, and 20 ml per kg. But before moving to the next bolus, you have to know your therapeutic end goal. What are you, or have you reached what you wanted? So when I say therapeutic end goal, it means the patient now is out of shock. If you have just given the first bolus, then you need to assess for if now this first bolus is enough, or should I give the next bolus? So if the patient is out of shock, well and good, you can just continue with maintenance. But also you have to be very careful. For kids, they are more prone to get fluid overload. How will you know if the kid is now getting fluid overload? The first symptoms, the kid will they will present with increased respiratory rate. And also you'll be able to palpate now the liver. And also the kids will present with bilateral crepitations. So you have to be very careful if you're a nurse who is monitoring the patient. So make sure you are monitoring the respiratory rate? Is it the same as when the patient is coming in, or now the respiratory rate is picking up? After giving 3 boluses of fluid, then and the patient is not responding, now you have a room of giving epinephrine or norepinephrine. And see if the kids are responding to the ionotropes you are giving. If still the kids they are not responding, now you're supposed to move to the next step whereby you can give steroid as it has been discussed before. So I think that is all I have. Thank you.
Yes, thank you very much, Dr. Raya. I hope our Raisi is well. We are proud of her. Now, you talked about a number of things which I do not want to repeat. However, just to emphasize, you said in pediatrics, we usually have sepsis and the main cause being respiratory issues. You also emphasized that as we are assessing for sepsis, we usually use SARS instead of the QSOFA, yes?
Yes,
Okay.
yes. Why do we use, sorry, maybe I should talk more about the SARS criteria. So because the SARS criteria does not give you how the respiratory rate to how much, because we know for the kids, they have different respiratory rate according to the age. I mean, their vitals are age dependent, not like an adult. Yeah, that's why we use the SARS criteria for pediatric. If you want to use it, you can just Google it, you'll get it, and it has a score and it will tell you what to do next.
Yes. Yes, and you also emphasize the use of caution while giving IV fluids because of risk of fluid overload. Thank you very much for that. It's been very helpful. And next, we are going to be having a presentation from our surgical expert, Dr. Kirabo. But before Dr. Kirabo comes in, maybe I'm going to request Sylvia to say something. Sylvia, are you still with us? Sylvia, are you still with us, our critical care nurse? Oh, yes. Dr. Raya.
Yes, yes.
No, not yet. There was something else which would request maybe you talk about viral and fungal sepsis in pediatrics.
So the common cause of pediatric sepsis in our setting is bacterial, but also we had like per year, we can have like 3 to 4 fungal infection, but is not very common. For us, common causes is bacterial infection.
Thank you very much. Okay, so I wanted Sylvia to say something. She's a critical care nurse and an emergency nurse, and maybe I wanted her, as she has been managing such patients, like the pediatric setting. Sylvia, do you have anything to say to the nurses out there when managing a ped with sepsis? Sylvia, are you there? Maybe something else to add on what Dr. Raya said, anything that we need to look out for as a nurse out there taking care of such a patient, and I'll request Dr. Kirabo to prepare as Sylvia gives us feedback on that. Thank you very much. Okay, so Dr. Kirabo is ready to take us through the next part, and we're going to have a look at surgical sepsis. Dr. Kirabo, you're welcome. I think we couldn't get so. Please continue. Thank you.
Thank you very much for the presentation. I'm going to look generally about surgical sepsis. Start with prevention. In prevention of surgical sepsis, I'm talking about how do we prevent patients from getting, patients who have had a big procedure, patients who didn't come to the hospital with sepsis, patients who are going for elective surgery, how do we prevent them from getting sepsis from the hospital? So one of the things that we follow, what the surgeons follow to prevent sepsis is the ERAS protocols, which are the enhanced recovery after surgery protocols. Some of the protocols, most of the protocols actually help the patient to recover faster after surgery, and they also help the patient not to prevent the patient from getting sepsis. And the ones I have picked out are the ones that are very important in this topic. Avoid prolonged preoperative fasting. According to the ERAS protocols, the prolonged preoperative, the adequate preoperative fasting for abdominal, for surgery that requires general anesthesia, for solid food supposed to be 6 hours, and then for clear fluids supposed to be 2 hours, and fluids that are not so clear, maybe 4 hours. And so let's make sure when we're going to operate the patient, let's not fast them for 24 hours or more. Some patients fast for, a whole day waiting for surgery. So also sterility in the theater helps to prevent sepsis. I think we've all been taught about the aseptic technique and, hand washing and all that stuff when we're dealing with wounds and dealing with patients in the theater. And early enteral feeding after surgery helps, the gut, helps to prevent stasis in the gut. And when it prevents stasis in the gut, it also helps to prevent post-op sepsis in patients who have had abdominal surgery. And controlled opioid administration. Usually, opioid administration should be, our intensivist here will maybe usually have opioid according to the pain that the patient feels, not just giving strong doses of opioids continuously. Sometimes we give only on post-operative day 1, and then you find the patients on post-operative day 2 can handle with only paracetamol, and this will help them to, achieve peristalsis earlier, for the peristalsis to be, adequate earlier after surgery, and to prevent sepsis. And controlled fluid administration is also very important, because when you give too much fluid is not good for the patient, because it's not good for the gut. Too much fluid causes edema of the intestines, and this can make a patient who came without sepsis get sepsis in the post-op period. Because if the intestines are edematous, there's a lot of flora in the gut, and it can transition to the blood vessels and cause sepsis. Also, early ambulation is important for the patient to get adequate, peristalsis and to pass stool and bladders, and also to recover early after surgery. And wound care, wound dressing. Sometimes we use vacuum-assisted closure for wounds that have taken long to close. Sometimes we use bedding, and some wounds require twice daily dressing, some wounds require daily dressing. I think it is all subjective when the team sees that wound and decides on what next to do. But wound care is very adequate in prevention of post-op sepsis. So in diagnosis, also early recognition is very important in surgical sepsis, because now I assume you're in the hospital receiving a patient for the first time, and maybe you've identified that the patient has sepsis, and the next step is to find out what is causing the sepsis. So early recognition that this is a surgical cause is associated with decreased mortality, because the earlier you recognize what is causing the sepsis, then you will intervene earlier. But the issue in most centers maybe is failure to recognize that this is a surgical cause and it can be reversed early. So early recognition is very important, plus aggressive intervention. So how do you recognize that this patient has a surgical cause of sepsis? Starts with clinical suspicion. Clinical suspicion may be in post-operative patients. Usually the earliest, the first parameter to get deranged is the heart rate. And in the post-op patients, usually post-op day 5, post-op day 4, you say a patient is getting a tachycardia, then your index of suspicion should be raised. You should be thinking that this patient may be getting intra-abdominal sepsis. The first post-op days, usually they can get tachycardia because of pain and what, but post-op day 5, post-op day 6, we expect them to have a normal heart rate and a normal blood pressure. So if they have tachycardias in that period, then you start thinking they may be having intra-abdominal sepsis, maybe they have an anastomotic leakage or something. History examination and investigations to find the focus of infection is also very important. In the most common causes of surgical sepsis, usually in our hospitals, is abscesses that need incision and drainage. There the patient will tell you the history and they have a swelling somewhere. Some patients will not tell you. They will come with a fever and they will not tell you they have an abscess, so you have to examine the patient from head to toe to see if you can find the cause of their fever or the cause of their sepsis. The other cause is peritonitis, which is a very important cause of surgical sepsis. Early identification in the abdominal exam. Usually the most important indicator in an abdominal exam that the patient has peritonitis is percussion tenderness. When the patient has percussion tenderness, that's the sign of rebound tenderness, and it is usually most patients who have percussion tenderness have peritonitis and will require an operotomy. But to back this up, you can do an abdominal ultrasound scan to see if there is fluid. And on ultrasound scan, the important indicator is the fluid in the abdomen. Does it have internal echoes? If the fluid has internal echoes, that usually indicates that there is pus or stool in the abdomen. Also, on the important indicators of sepsis in the elderly usually don't get a tachycardia, but they usually get their mental state, they usually get delirium. Most elderly patients who come with sepsis they may not have fevers, may not have tachycardia, their heart rate, their blood pressure may be normal, but they may present with delirium as the only presenting complaint. And when you examine from head to toe, you may be able to find the cause of their sepsis. And this is for early identification, so that you don't identify that the patient has sepsis when they are already in septic shock and all the parameters are deranged. And in investigations also I talked about the abdominal ultrasound scan for peritonitis, which is the common cause, and also the X-ray for peritonitis, and X-ray is a very important investigation because it shows the air under the right hemidiaphragm, which is an indication for gut perforation. And if in a setting that can do a CT, you can have an abdominal CT done. However, it depends on the setting you're in. Some settings don't even have X-ray, they only have abdominal ultrasound scan. In some surgeons who have worked in very low resource settings, they will just use their clinical acumen, their abdominal exam to, note that this patient needs an laparotomy, especially if the patient has percussion tenderness that is so generalized, abdomen is distended. Sometimes it's at night, the sonographer is not around, the X-ray person is not around, you might have to, that should be enough for you to say this patient needs an emergency laparotomy to control the sepsis. And then for diagnosis also, I was talking about the common causes of sepsis. In surgical sepsis in the abdomen, we have peritonitis, appendicitis, cholangitis, cholecystitis, full blood that can also cause sepsis, urinary retention can also cause sepsis, especially in the elderly, because some of them don't feel that they have a full blood, they just come with sepsis. and you will identify in registry at clinical exam that this patient has gallbladder, for example, septic shock. In the chest, can be an empyema. So all these you should be able to recognize them with a history and a clinical exam and to make a proper diagnosis so that the intervention is aggressive and it is early before the patient deteriorates and they need ICU and other support. In the management of surgical sepsis, so my colleague, the intensivist, Dr. Lubikire, has talked about the fluid support and the vasopressor and the steroids, which are also in the management of surgical sepsis, because we start with the medical management, resuscitating the patient. We don't rush the patient to the theater. We start with resuscitating and discuss with the intensivist or anesthesiologist to see if the patient is ready to have the surgery. For definitive source control. This is for a patient who has come with sepsis, or maybe they have developed the sepsis on their own and they have already deteriorated. They may need fluid support. Sometimes they may need vasopressor even before they come to the theater, and they continue with the vasopressor. They may need to be admitted in an ICU, cultures and appropriate antibiotics, like we had earlier discussed, organ support, consider blood transfusion if appropriate. For patients, according to the surviving sepsis guidelines, blood transfusion is usually given for patients who have HB of 7 and below. Then definitive source control within 12 hours is a very important point in management of surgical sepsis. For example, for an abscess, we need to do incision and drainage. For peritonitis, we need to do a laparotomy. For necrotizing fasciitis, you need to do debridement. All this within 12 hours. So the fluid support, the vasopressor, the steroid, the resuscitation should all be done within 12 hours so that you have a laparotomy for this patient as soon as possible. And then for surgery for these patients, usually like to do damage control surgery. You work as fast as possible so that the patient, does not deteriorate in the theater, and the physicians are able to continue, their care for the patient without, So damage control surgery means you work as fast as possible to control the source. Usually within 1 hour, you should be out. For peritonitis, which is the most common cause, an important point is make sure to wash out all the recesses of the abdomen, the subdiaphragmatic spaces, the right and the left, the subhepatic spaces, the paracolic gutters, and also in between the intestines. So when you do a very good washout, we expect quick recovery, and the patient may not need other washouts, or they may not even get wound dehiscence. But usually the issue is with peritonitis. Sometimes the washout is not good enough. And even with antibiotics, the patient may need other relapse to wash out more. Yes, thank you very much.
Thank you very much, Dr. Rachel. She's also Dr. Kirabo, so I keep interchanging. I hope that's okay. Yeah, thank you very much for that wonderful presentation. And those of you who have been very keen, she talked about early recognition as being very important. Early recognition. Are you able to know this is sepsis from the word go? Yes? Then source control. The surgical team says source control is very important. Yes, I have noticed that we have Dr. Kaweru on call, and I'm inquiring, Dr. Kaweru, if you have a comment. Yes, Dr. Kaweru, do you have a comment in line with what we are discussing?
Thank you very much, Dr. Chirabo. I didn't know that he had already noticed that I've been on call since then, but I would wish to thank the presenters, Dr. Agre Rubikire and Chirabo, and the other one, I've forgotten the name. Now, surgical sepsis is one of the most difficult things, actually, sometimes to manage, especially if you least anticipate it. And when it comes to resuscitation, sometimes people think about giving IV fluid, but it is beyond fluid. Sometimes you end up actually having issues to do with albumin, and you may be infusing other third space. So sometimes it can really be very challenging to manage, especially intra-op and post-op. So what Dr. Chirabo said is very true, that you need to anticipate it very fast, prepare for it, and not only in terms of IV fluids, antibiotics are key, but even volume, as in pressure support management, and you need to prepare for your ICU, because these patients actually can end up getting organ failures, and they can give you a run of your skills, run of your experience, and a run of your money. So Dr. Chirabo was very precise to tell you that actually you need to prepare in time. What you may be going for is not a 1 minute thing. It is something that actually you need to collect as a team. And obviously you need to set your high care services at the topmost, because these patients don't end up on ordinary wards. And if they end up on ordinary wards, it is very difficult to save them once in a while, because they need a lot of support in the different systems. So I don't want to say much, but thank you very much, and thank you for giving the opportunity to say a statement.
Yes, thank you very much, Dr. Kabwiru. But before you go, maybe you could highlight the role of Decasan in source control.
Oh, Decasan, I've used it before, and I think it can be very good, especially if you like, for instance, if you have like peritonitis and then you want to wash out, it may be a very good one. And even in chest, we don't usually use it, but it would be a very good one because it has that antibacterial and then antiviral properties. I don't know whether it also has some antifungal. I really don't know, but it would be a very good one.
Okay. Okay. I want to thank you for that very educative bit you have given us. Someone was commenting that your voice was so low, some of them could not hear you. But for those who could hear, we want to appreciate. And I also want to urge people or the participants to keep typing in the chat box any questions that they have, because we'll be soon going into the Q&A session. But we want to recognize also the presence of people from Kirudu Hospital. We also have people from Arua. We have people from Busitema University. And I noticed we have someone from Malawi. Yes, you're welcome. We also have people from the Uganda Private Midwives Association. Thank you for joining us. Others from as far as Yumbe. Thank you for joining the session. And others from Mulago Hospital. You're welcome. So let us continue to the next session. I am going to welcome Dr. Sonia to take us through an approach of sepsis in a high resource setting. For those of you who are not with us before, Dr. Sonia is also called Sonia Jarrett, and she's a pediatric fellow, and she's from Boston Hospital. Dr. Sonia, you are welcome.
Yes, perfect. Thank you again. So I'm going to share my slides. So I think everyone has already, Dr. Raya Musa already discussed the pediatric sepsis management. So I will not take time to review that now, because I want to make sure there's enough time for questions. But just to make sure that everyone, it's just one picture to highlight, either high resource or limited resource setting. The most important thing for patients with sepsis is that we really have like a time urgency to treat these patients. So it doesn't matter where you are or what type of resource you have. The most important is to recognize it early and then try to treat them early. So that's like universal, most important point for these patients. So depending on what you have available, I think we'll discuss some of the high or low or limited resource setting differences. But I just wanted to highlight one point that I saw in the guidelines from 2020 from the Surviving Sepsis campaign. There is one thing that they wanted to differentiate for patients depending if you have a ICU or if you do not have an ICU. You may want to consider some differences in the fluid management for these patients. So for children, at least, they say if you are working in a hospital or in a setting with intensive care services, then they say you can bolus, more. And because usually in those settings, if you have fluid overload, the ICU can manage. Ideally, you do not do fluid overload. You always want to be careful with these patients, but you do want to do more urgent fluid resuscitation. So in places with the intensive care, you can consider to give bolus from 40 to up to 60 milliliters per kilogram. And then in locations where you may not have the intensive care availability, then you want to be more careful with the fluid management. Sometimes if there's, of course, no hypotension, you do not want to give boluses, you just start maintenance fluid. And then in a place where the patient is having low blood pressure, but there's no ICU, then you just give slower boluses and try to limit it a little bit more, up to 40 milliliters per kilogram. I think these I'm going to pass over because we discussed some of the pressor management, but even in high resource setting, we still are mostly using either epinephrine or norepinephrine for the treatment of shock with sepsis. There has been a lot of discussion of steroid management, and the main thing is that currently we still say that you do not use it for every patient. You have to consider their whole picture before you give the steroids. So getting just to two final points for the higher resource settings, this is just a long list of antibiotic choices that you may consider depending on what you have available at your hospital. Usually in the setting where I'm working, we standardly start with ceftriaxone, vancomycin as like two of the main antibiotics. And then if the patient is having an abdominal type infection like the patient we saw from this case presented today, then you want to add on something with anaerobic coverage, such as metronidazole. Other patients, if you're immunocompromised, we use something different. We use cefepime. This one can cover Pseudomonas for an immunocompromised patient, which is different than the ceftriaxone. And then if there's a patient with oncology history, we also sometimes consider meropenem, which is even more strong and broad. Questions so far? I just want to make sure I discuss two, or actually one more slide, I believe, some additional considerations for sepsis management in the high resource setting. We also, depending on your medical record system, if you have an electronic medical record, sometimes if you already enter the vital signs for each patient when they present, there is a way for it to highlight and say, is this patient at risk for sepsis? So that is a tool that we use here. Then when there's a patient that has tachycardia, tachypnea, or hypotension, then it will give us a flag on the medical record to say, we are worried about, or the computer will tell us, are you worried about sepsis? And we go and discuss with the team and evaluate that patient quickly. Of course, I think in many cases, we always will get the blood culture before antibiotics, but I know that depends on your microbiology lab if you can have the cultures run. And we also, for fluid management, we use often a pressure bag or a rapid infuser, something that can give the fluids more quickly to the patients who are experiencing shock from sepsis. And this maybe also you have available as well, but that's something I wanted to highlight. And we do often use a bedside echo, looking, like Dr. Musa had mentioned, at the IVC, but also we look at a bedside echo to see if the heart is squeezing normally, if there's other organ dysfunction. For pressors, often we prefer to have a central line just to be able to be safer for the blood vessels. Those are really the main considerations from the higher resource setting. I'm happy to take questions.
Thank you very much, Dr. Sonia. And in line with what you were saying, there was actually a question. Maybe we could start with you. Someone was inquiring about the use of hypertonic saline in sepsis or septic shock versus use of colloids.
Great. So usually we tend to use like crystalloid fluid. I think, do they mean hypertonic saline or just normal saline? That's just one thing I want to clarify.
This one I was inquiring about hypertonic saline. However, let's talk in line with what you're saying as well.
Sure. So I would just make sure to differentiate for hypertonic saline. Usually I would use that for the patients who are having mental status change or head bleed, or you're worried about increased intracranial pressure. The normal saline and other crystalloid fluids, those would be the main ones that I use for the sepsis management.
Okay. Thank you very much, Dr. Sonia. And other questions are coming on. I am still encouraging people to keep posting their questions in the chat box. We have a number of them here. I'm going to request our experts to be ready to educate us more on this. However, maybe one thing that Dr. Sonia emphasized was that in sepsis, we are talking about early recognition, and we are emphasizing treating early. She also talked about fluids being different given whether you have an ICU or not. Yes? Okay, so we are going to start with, there was a question they gave, someone posted here. They were asking that, and this goes to you, Dr. Agre, the use of dopamine in septic shock.
Thank you so much. Adrenaline, noradrenaline, dobutamine, bisoprolol, arginine vasopressin, ephedrine, phenylephrine, all can be used. However, when you're managing shock, you have to look at just the physiology of what is making cardiac output and maintaining the blood pressure. So every cardiac output is the stroke volume times heart rate. The drugs we use have different receptors. Dopamine specifically works more on beta 1 than beta 2 than the alpha. So that means you're increasing inotropy, and beta 2 will be for chronotropy, and alpha 1 will be, the alpha will be for vasopressin or vasoconstriction. And what your target is to press the pipe before you address the issues of the heart, because most times the heart is working very well. So if the issue is the heart, dopamine addresses the issue much better. In lower doses, the butamine vasodilates actually the renal vessels, so it will improve renal function. And yet it's not our target. Our target is to improve general body perfusion. So the research that has been done does not recommend it as a first-line drug. The first-line drug are drugs that work on the alpha, And that means we use noradrenaline. That's why it's part of the 1 hour sepsis bundle, because of its receptor, receptor effect.
Yes.
So it can be used, but only as a last resort. But in a challenge where you have it as the only drug, yes, you can use, and you'd have to use higher doses, about 15 micrograms per kilo per minute. If you use lower doses of 0.2 to 5, you'll only address the kidney, and yet you want to address the whole body. So the first line drug is noradrenaline. You pick bank up with adrenaline, that's agonine vasopressin, then dobutamine comes as the fourth drug there.
Yes. Thank you very much, Dr. Agri. I'm hoping the people who have asked these questions are noting down, and we want to continue. We still welcome and recognize people from different areas. We have noted that people are joining. We have someone from Nalufenya. Thank you for joining us. And we are seeing people from Zombo, and then Bombo, Kasese. You are all welcome. Thank you for joining us. Yes, also Ngando Health Center, you're welcome. There's someone as well from Mulaji Health Center. Now, I am going to request Dr. Rachel maybe to give us her take on this. Someone is inquiring, how early should enteral feeding be initiated after surgery? And they gave an example of gut anastomosis.
So for gut anastomosis, usually we start enteral feeding on after 24 hours. Okay, that's what we are doing, but there are studies that have been shown that that's what we're doing in Mulago. But there are studies that have been shown that it can be safe even after 12 hours in other settings. Yeah. So in your setting, you can do 24 hours. You can do sometimes what is the ERAS protocol was going against people who are waiting for someone to pass through before they start feeding. So passing through may take a long time, may take or waiting for maybe bowel sounds to be adequate, or waiting for flutters. So that one may take like 36 hours or even more, or even like 3 days or 4 days. But what we want to go against is that when you give someone something to drink, it will stimulate the bowel sounds to, the bowels to start moving adequately. So usually on post-op day 2, post-operative day 2 after anastomosis, I think it's good enough to start.
Okay. Yes, Dr. Agri wants to add. Yes, thank you.
Yeah, so in a good center, we're able to run lactates. The gut is one of those organs, when you're in shock or you have pathology, produce a lot of lactates. So hyperlactatemia is a poor perfusion index. So if your lactates are falling greatly well to expected prediction, you're right there enough to say, I can start oral intake.
Okay. Yes, thank you for that addition. Maybe there was a bit where you said, Dr. Rachel, that in some settings they are giving, rather they can initiate even at 12 hours. Well, what are those things they're looking at? What prompts them to start that early?
What you said,
the lactate. Yes. Oh, lactate levels. Okay. Okay, thank you very much. So I am going to, there are some other questions. I kindly encourage you to post, and someone was asking, that you throw more light on how preoperative, okay, the English here is failing me. Let me say that again. Preoperative prolonged fasting predisposes the patient to surgical sepsis. Does it make sense?
Yes, because preoperative prolonged fasting.
Oh, okay. I get it now. Yes.
If the patient fasts for longer, let's say they're going to have a surgery and they fast for the whole 24 hours, usually it makes them to take longer to recover from the surgery. Something about the physiology of the body, the patient. I think this will tell us no, but the physiology, the patient takes longer to recover after surgery. So even their immunity and the ability to fight an infection, fight off an infection, or the whole recovery process takes longer. And also when the patient fasts, the intestines don't, let's say, move. When the patient fasts longer, food stimulates the intestines to have peristalsis. So when you're fasting, there is more stasis in the bowel, and we have a lot of flora in the intestine. So when there is stasis, there is a higher chance of this normal flora in the bowel to transition or to, let's say, like from absorption or something into the system, the systemic circulation, move into the systemic circulation. So what we're trying to prevent is stasis of bowel for a long time, for an unnecessarily long time. So that's why we reduced on the time of fasting and also reduced to the time of fasting post-op and pre-op.
Thank you very much, Dr. Rachel. There was, excuse me, someone was still inquiring how we could differentiate viral sepsis from bacterial sepsis. I don't know if Dr. Raya, are you still there and you could say something about this? Dr. Raya?
Yes. So actually it's difficult to differentiate clinically between viral from bacterial infection unless you do the blood culture or next generation gene sequencing. Then you'll be able to pick if the sepsis is from viral or is from bacterial.
Yes. Okay, thank you very much for that response. There is someone who has a question, but was inquiring. This comes to you, Dr. Raya, where they are inquiring. Maybe Ezekiel, are you there? You could unmute and just pose this question direct to Dr. Raya. Ezekiel, are you there? He's Ezekiel Dapa.
Yes, I'm here.
Okay, please, Dr. Raya is ready to answer. Just give her that question.
Okay, she mentioned something about respiratory. She differentiate between the two, but my inquiry is to know how to handle the management if a patient with the patient with respiratory distress and the one with respiratory failure, is the treatment approach the same or different?
Okay, thank you, Ezekiel. The approach is different. If patient is coming in with a respiratory distress, then you can just supply with the oxygen supplying device. For example, you can use a nasopronts or you can use non-rebreather mask. But when the patient is coming in with a respiratory failure, it means the patient is now unable to respirate appropriately. So you need to help this patient to get back to normal respiration. So what you do, you're supposed to intubate this patient and put this patient on ventilator.
I hope you have been answered. Thank you very much, Dr. Raya. Yes, we want to continue to encourage you to type in more questions. There is someone called Richard Ainomujisha. Could you unmute and ask that question, please? And I guess this, Dr. Sonia, kindly take on this. Yes, Mr. Richard Ainomujisha.
Thank you so much. I'm Richard from Action Bay. Hope you can hear me. Can you hear me?
Yes, please.
Yes. While I'm a dermatologist, while at school, we had a very big discussion with physicians when they could come to see our patients who had sepsis secondary to 10, and they would really have a big say on not to initiate hematinics, especially when there is low HB. So what is the science behind or not initiate hematinics in sepsis?
Dr. Sonia?
Yes, it was. I did not hear exactly the last part of the question. And maybe it's written and I'm looking in the chat to confirm.
Yeah, he was.
Paraphrasing.
Okay, Dr. Agri is going to paraphrase it. Thank you.
Sonia, he was asking why we are not, or why we have contraindication to giving hematinics in patients that have sepsis.
And to clarify, hematemics, I don't actually use that term as much. You mean fluids?
No, to boost the HB. He's saying like if a patient has a low HB.
Blood transfusions.
Iron supplements.
Okay, understood. So I think in this case, truthfully, I'm a little less familiar because I only see the patients in the emergency setting, and usually we send them to ICU afterwards. So maybe Dr. Agre, this might be a better question for you. I don't typically do iron in the emergency room. We first are finding out, their hemoglobin and also their, fluid status in the very beginning. But I know the main thing is we do want to make sure we're not giving too much fluid to anemic patients. I think someone had asked me a question on that separately, and it's correct. We do want to make sure the boluses are not lowering them and diluting them too much. But as for the iron therapy, I have to admit I'm less familiar. And maybe someone else can comment.
Okay, Dr. Agre is going to take that on, but before that, I encourage you, if you have questions, maybe you could raise your hand. We're going to give a chance to a few people so that we can, Okay, Dr. Agre, please.
I think that the old teaching was because of the fear for capsulated microbial organisms, the parasites or bacteria, that they needed iron for their survival and for their replication. Hence, the fear was if you give the iron, then you encourage the prevalence or existence of the other antimicrobial that you're trying to overcome. But with the current antimicrobial molecules we have, if you're giving the right dose and at the right time and at the right concentration, I think that's no longer an issue. But also the kind of patients, if the patient is in critical care unit, and you don't need to give them iron supplements, because then you'd rather correct by giving the actual blood to improve their perfusion than taking forever, because that's going to increase morbidity in the ICU. So unless the patient is not in ICU, then I would actually maybe give them the iron supplements. But if they're in ICU, I would rather actually replace the blood and improve their perfusion so that they have less stay in the ICU.
Okay. Thank you very much, Dr. Agre, and I hope that has helped Mr. Ainomjisha to understand this better. Yes, we encourage those who have questions. We are going to, you can raise your hands and then we give you an opportunity to ask this. Well, someone is talking about the use of distilled water in management of sepsis. Yes? Have you heard of that?
Distilled water has no role. Yes, it's a crystalloid, but with no salt. So we either use crystalloids or colloids like blood or albumin. And the closest crystalloid we can use is, I think, maybe rhizoblac in our environment, which is hyperosmolar. But otherwise, steroids, distilled water, tap water, mineral water, we have no role. However, maybe if you are having acute kidney injury, you have severe malaria, you have a kidney injury, you have severe maybe dengue or dengue shock. I saw that in India. Actually, they encourage you to take as much oral fluids as much as possible before you reach in the hospital setting so that you avoid going into dengue shock. So probably that can help. But yeah, you may be too sick and you may aspirate on your own fluids at the same time. So not advisable.
Yeah. I hope that has helped to make for our comprehension. We have Mr. Lomilo George. You had raised your hand. Mr. Lomilo George, are you there? You had raised your hand. Please pose the question if you're ready.
Thank you so much for the presentation. Mine is not question. I have heard of adrenaline drip whenever we have these patients of septic shock, and I would like Dr. Agure to clarify about it. Thank you.
Yes.
Yeah, thank you so much. We normally use adrenaline as a poor man's solution to that problem. Most of the regional referrals do not receive regular noradrenaline. So half the time we have actually adrenaline as our first go drug. So adrenaline actually can be used. The other challenge we have in regional referrals, we do not have, unless you have an ICU, but most places on the world do not have infusion pumps. So occasionally, yes, in terms of called me to ask how we can run adrenaline, and normally you have to put a whole microgram, 1 milligram, sorry, which is 1,000 micrograms in the 500 mils. And depending on the level of shock, you will titrate effect. That means you can run about 10 to 20 drops until you start getting a good systolic blood pressure, or you just use a mean arterial blood pressure, which is the best thing to do, until you get a mean arterial blood pressure of 60. The challenge is, as you increase the rate, you may actually drive a lot of, initially beta 1, which would be good. You get a lot of inotrope, so the heart improves in pumping. But if you start increasing the dose, you start also getting beta 2 effects. Then you start getting all these arrhythmias. And remember, cardiac output is equal to stroke volume times heart rate. So if you're increasing the heart rate, then also you're jeopardizing your cardiac output, because the heart needs to be beating in a regular fashion, not an irregular fashion. So the higher the dose, the more counterproductive it is. So you reach a point also, if you give higher doses, then you cause more vasoconstriction. If you are giving the person maybe like Doreen, you might find her getting blue fingers after that. If you're giving high doses, like maybe 3 vials. So you are getting good pressure, but vasoconstriction. So she starts the purple syndrome as well. So it's always good to try and advocate to get noradrenaline and adrenaline. So that's how they rationally go. And then if that fails, then we go to agonine vasopressin, or we use some dobutamine. So the best thing is to use smaller doses of each drug and use them in tandem. So they are going to be synergistic so that you avoid a lot of side effects, as opposed to just using one drug in high doses. So it's like cooking. If you're cooking, you don't use only salt. You do a bit of onion salt, a bit of meat cubes. A little of each brings out the broth very well, and without a lot of side effects.
Yes, thank you, Dr. Agre. You said I would turn purple? The fingers will turn purple?
Because of the vasoconstriction.
Okay. Those who are dark, maybe they would turn a different color. I don't know. Anyway, so thank you for that response. We had also Benjamin Ochuka. Mr. Benjamin Ochuka. And as you give us the question that you had, kindly unmute and give us. However, there is also the post-test right now. We encourage you to take on the post-test. Yes, the post-test is on. Go ahead and fill in that post-test. We want to know, has this been useful? Has learning taken place, as some people usually say? Okay, so Mr. Benjamin Ochuka.
Yes, thank you so much. I wanted to find out, since I've forgotten the name of the doctor. She said it's not easy to identify or to distinguish between viral sepsis from bacterial sepsis. So how best can we manage such a patient? Do we need to introduce antibiotics? Should we manage the patient? Should we give just supportive treatment for such a patient? Because not every facility can manage to do culture and sensitivity, yet we are supposed to help this patient survive. Then I also had a question on the indication of thiamine. Then at what dose do we give thiamine?
Yes, thank you very much, Mr. Ochuka. Just to clarify, your first question was about differentiating viral sepsis from bacterial sepsis. especially in a low resource setting where you cannot do culture?
Yes. And how best can we manage such a patient?
Okay, Benjamin, I'll take your question. So even for us, we don't have such luxury of doing a culture immediately or doing the culture for all patients who have indication. But what you're supposed to do is to start this patient on antibiotic within 1 hour, because the most common cause of sepsis in pediatric patient is bacteria. So start this patient on antibiotic within the first hour on arrival in this.
Is for that IT glitch. Yeah, let's continue. Dr. Raya? Dr. Raya?
Yes, I have already responded to the question. I think you had connection issue.
Yes. Now,
Yeah, so thiamine is one of those drugs that actually it's first of all it's a vitamin D. One, it's toxicity. So while having tried, the smaller the dose, the less the effect, but the higher the dose, the better. So most studies have actually encouraged between 500 milligrams 8 hourly to at least a minimum of 72 hours. And where you suspect that there's going to be a bit of sepsis-related acute kidney injury, we do a prophylaxis of 100 milligrams 8 hours straight away, for at least a minimum of 72 hours to 5 days. So yes, the dose varies on the severity of the patient. You can start low and increase.
okay. Yes. Mr. Benjamin Ochuka, I hope you have been answered. Now, I encourage you all to take on the post test. Would like to understand. Yes. Carry on with the post test, please. Let us see how we are performing versus our pre-test. And also, Sylvia, are you there? There was something that Sylvia was meant to answer. Are you there, Sylvia?
Sorry now.
Okay, maybe a question to you. You are working in a state-of-the-art hospital setting, and as a critical care nurse and an emergency nurse, what are some of the challenges you have experienced, and maybe you could help others out there to anticipate these as they are managing a patient with sepsis?
Okay, thank you very much, Doreen, for that question. As we have been managing, as I've been managing these patients with sepsis, the major challenge is actually infection prevention and control. And I want my fellow nurses to be aware of this. As we are managing these patients with sepsis and septic shock, we should use proper infection control protocols, use the appropriate PPE, if possible, use a gown, aprons, a surgical mask, and always wash your hands before moving on to the next patient. Because if you're not careful, you may pass on these infections or these bacteria or viruses to other patients. And in most cases, we need to use barrier nursing, strict barrier nursing. And it's sometimes challenging when you don't have enough manpower, because you're supposed to be the people caring for that patient. they should be strictly only attending only that patient and should not be moving around attending to other patients, which is really hard in some settings. So we should try as much as possible to use the proper infection control protocols, use the PPEs, wash your hands as much as possible, sanitize before touching the patient and after, so that you prevent passing out these bugs to other patients.
Yes, Sylvia, thank you very much. We have heard from the expert. I hope nurses out there can also pick a leaf from that. I encourage you to continue with the post-test. And we have only a few minutes to go. So what are our take-home messages from this presentation? Most of the specialists, our experts, talked about being able to recognize and treat sepsis, and they also emphasized good assessment. Dr. Agri talked about the ABCDE, and they also talked about the different tools that we can use to see if this patient has sepsis or not. We have a few minutes to go, but I would like to thank everyone who has attended this session. We are going to start with the participants. We appreciate you, all those who are on call, wherever you have logged on from. And we want to thank especially our presenters, our experts on this subject matter. We want to thank Sylvia Anans from Critical Care and Emergency setting. We also want to thank our critical care specialist, Dr. Agre. We want to thank Dr. Raya, an emergency physician from Muhimbili National Hospital in Tanzania. We would like to thank also Dr. Sonia Jarrett. She's a pediatric fellow from Boston Children's Hospital. We also want to thank Dr. Rachel Kirabo, and we want to thank MOH, Ministry of Health Uganda, for this initiative that is empowering health workers across the regions. Also, the partners, Seed Global Health. And I want to thank the people in the background, the ones you're not seeing, Dr. Ibrahim and Dr. Thomas. Thank you very much. Are we able to see? We are done with the post-test? Yes, we seem to be done with the post-test. Yes.
So we are done with the post-test. Thank you, all of you who have answered the post-test. The answers are being shared. Most of the participants chose the right answers, except for question 5, where we have only 47% of the participants getting the answer. So question 5 is the one saying, which of the following is contrary to the initial goals of resuscitation for septic patients? And the answer was immediate transfer to the ICU, but we've had a number of participants say restoring intravascular volume, diagnosing the source of infection, and then source control. So I don't know if the experts are willing to talk about that.
1 hour bundle, I think. Does it take us back to that?
Can you just read the question?
The question is, which of the following is contrary to the initial goals of resuscitation for septic patients?
Yeah, anyway, I'm not really sure what the other options were, because I've not looked at the questions. But our initial resuscitation is based on the sepsis campaign, surviving sepsis campaign, which is the 1 hour bundle. And in that 1 hour bundle, we measure serum lactate, and our target should be anything less than 2, anything above 2, then we should start worrying. We obtain blood cultures for both aerobic and anaerobic infection from different sites of the body. We do a broad spectrum antibiotic, And if it's already given prior to the cultures, then you ask for an MIC. We do 30 mils per kg of crystalloid resuscitation so that we improve our lactate state, especially for lactates where we are heading above 4 millimoles per liter. And early use of vasopressors, noradrenaline recommended to target a mean arterial blood pressure of above 65.
Yes, Dr. Agri, thank you very much. Dr. Rachel has something to say as well.
I just want to say in this question, like Dr. Agri said, when you get a septic patient, the goals of resuscitation should be clear. And this question was asking which of the following is contrary to the initial goals of resuscitation. And the answer was immediate transfer to the intensive care unit, because this is not a very immediate transfer to the intensive care unit is a very important thing right now with the 1 hour band and the immediate resuscitation of the patient. Because what if the patient needs the surgery, then you have to bring them back to the theater. So that was the correct answer. However, I think most people were saying restoring intravascular volume is not very important. But now when you look through the answers after this presentation, you realize that the other options are more important than transferring the patient to the ICU.
Okay, thank you very much. Now, if we can, we do remember the take-home points, yes? I remember Dr. Agri said, sepsis is a pandemic. Yes, in case you did not know, this is a pandemic. We've already said COVID-19 is a pandemic, sepsis is a pandemic. Please take note of that. And we no longer have severe sepsis. We talk about sepsis and septic shock. Yes, and other things that we are taking home, I guess every one of you has been noting. Okay, so he also emphasizes that septicemia is no longer a diagnosis anymore.
No, so from the Surviving of Sepsis campaign that has been a build up from the 2016 to the 2018, from 1991 then to 96, there's been a lot of change from SARS criteria. Many things actually mimic sepsis, but they are not really sepsis. But also, where you tell if someone has SARS, doesn't mean actually SARS criteria, doesn't mean actually someone actually has organ dysfunction. Like here, when someone has respiratory distress, it's different from respiratory failure. If you have a failure, it means actually you have an organ already affected, so that person is already having signs of septic shock. So when you look at the SARS criteria, it describes the prevalence of toxemia or bacteria in your blood or parasitemia, and that mimics the condition of septicemia, but does not actually define what's the ongoing pathology. It just shows the prevalence of what's causing you the problem. So just, you can have varying levels of bacteria flowing in blood, but doesn't mean actually if I'm having that varying levels, actually my organs are failing. So that's why we only have two definitions to avoid confusion. It's either sepsis, that means you have organs failing, or septic shock, when you have shock that is not responding to fluid and may need to get vasopressors on board.
Yes, Dr. Agri. And we are encouraged to turn on our videos so that we can take screenshots. Kindly turn on your videos so that we can take screenshots. Thank you very much. This will take only a short time. Yes. Is that good enough? Okay.
Thank you, participants that have turned on the videos. We are happy to see you. I want to let you know that at least we have made a year doing these sessions. So we are so happy to see people who have been with us from November 2021 up to date. Someone is asking about a birthday cake. We shall send it on email. And the materials for the session plus any further coming sessions, we store them on the microsite. So we encourage all of you to visit the microsite where we store most of the materials. We have our last session this year, which is going to happen next Friday at the same time. There are sessions, so I'll be happy to see all of you. I'm seeing Pius Renon with a baby. We are happy to see the baby. I hope the baby will grow and become an eco coordinator.
Beautiful smile there.
Thank you, all of you. Enjoy your Friday and the weekend. Please do not drink and drive, but you can drink and stay in the bar, but don't drive.
Drinking.
Sister Charity.
Sepsis.
Sister Charity, you look good.
Over drinking might get
Thank you so much. We're happy to see you. Bye-bye.
Bye for now. Thank you.
And a Merry Christmas.
Oh yes, Merry Christmas.
Merry Christmas is
after this session.
Prepare to this session. Me because I've not wished them.
Oh, okay.
Freezing.